So the Alaska Native Tribal Health Consortium has an ambitious vision that Alaska Native people are the healthiest people in the world. This vision is rooted in the strength of Alaska Native people and cultures. ANTHC is designed to meet the unique needs of Alaska Native and American Indian people living in Alaska. It serves over 180,000 people throughout the state. Provides high quality health services, including medical services at the Alaska Native Medical Center, wellness programs, disease research and prevention, rural provider training, and rural water and sanitation systems construction. So this training is brought to you by two programs within our wellness and prevention department, and this department promotes wellness through culturally responsive prevention services. We work with community health workers, community members, and volunteers in a multidisciplinary and holistic approach. And the two programs that collaborated to create this training are the substance misuse and HIV STD prevention programs. The substance misuse program goal is to prevent substance misuse, and the HIV STD program goal is to reduce the prevalence of STIs and HIV, promote sexual health, and promote healthy relationships. And these two programs come together to provide free health resources to the community. And this includes harm reduction supplies and education materials. So feel free to visit our site, which is iknowmine.org, to have a look at our shop full of resources and to order free supplies for your community. So as I said, this is the first of our harm reduction trainings. And during this training, we're going to focus on the unique needs of Alaskan communities, hear from Alaska-based experts, and learn about Alaska-based resources. The goal is to increase the well-being of individuals in our communities by reducing the harms associated with drug use. What is harm reduction? It's a set of strategies that seek to reduce the harms, legal, social, or health, associated with drug use and drug policies. It's grounded in social justice and respecting the rights of people who use drugs. It includes interventions to reflect individual and community needs. And it demands access to non-judgmental care programs and policies that promote optimal health and social inclusion. So some examples of what harm reduction could look like are exactly what we're talking about here today: disease prevention and management. So today's training will teach us more about HIV in Alaska, resources for prevention and testing, and care for people with HIV. And this is an example of reducing the harm that could come from substance use. We're very honored to have our two experts from ANTHC's Early Intervention Services team with us today. We have Lisa Ray, the registered nurse, and Lorelei Riley, the senior program manager. And I'll pass it over to Lorelei to give a bit more of an introduction and introduce herself and Lisa.
Thanks, Marla. Good morning to everybody. It's so nice to see a bunch of familiar faces and also a bunch of people that I haven't been able to meet in person yet. So hello, everybody. My name is Lorelei Riley, and I've been the Senior Program Manager for the Early Intervention Services Department at Alaska Native Tribal Health Consortium for the last 6 years. So the Ryan White Part C program is actually a component of the HRSA Ryan White AIDS program, and we provide comprehensive HIV healthcare, intensive case management, and support services in an outpatient setting here in the internal medicine clinics at ANTHC for people living with HIV throughout the state. We have been a Ryan White Part C recipient for the last 18 years. Our medical director, Terry Bramall, was actually one of the first authors to write the proposal to HRSA for us to be able to provide these processes, these systems, and these services throughout the state. And Lisa Ray, as an RN case manager, has been with us for about 10 years. And so we've got some longevity on the team with some subject matter experts that have really been able to mold the needs over time and really make some great community partnerships, and also find out what resources are available throughout the state to really support the people that we serve. So without further ado, I would like to switch it over to Lisa Ray, our RN case manager, for our wonderful presentation today. Lisa?
My name is Lisa Ray. I'm a nurse. I work at Alaska Native Tribal Health Consortium. I graduated from the University of Alaska in Anchorage in 1997. I've worked as a public health nurse at the STD clinic here at the municipality. I've worked as a sexual assault nurse examiner. And for the last 10 years, I've worked here at ANTHC as a nurse case manager in the HIV program, and also I've worked with the STD program here. This is the team that I work with. There's a few additions. Terry Bramlett is our program director and medical director. We work with PA Leah Besh, who also works in our hepatitis program. We work very closely with the two infectious disease doctors, Dr. Gray and Dr. Schneider here at Alaska Native Medical Center. I also work very closely with Tor Brentro, who works for South Central Foundation. He's an HIV case manager for the Anchorage-based patients. But in Alaska, a lot of Alaskans travel, and we travel back and forth between rural areas and Anchorage. So there's quite a lot of overlap between our jobs, and we share things quite a bit. We also have three case management assistants: Linda Hogans, who's a CMA, Gigi Guthrie, and then Matthew Mulhern, who's an intensive case coordinator who helps us with patients that maybe need more intensive services. This is us in the times of COVID. Like everyone and all of you, we all scrambled to continue to do our jobs in a different way, just like I'm doing this presentation now via Zoom, so versus in person. With what we do, is we see Alaska Native patients, healthcare beneficiaries here at Alaska Native Medical Center in the internal medicine clinic. We also see patients all over Alaska. We do field clinics to hub sites for HIV care, and we will consult and co-manage with any patients that are living with HIV and their providers anywhere in Alaska. They don't necessarily have to be Alaska Native beneficiaries. There are places in Alaska that have patients living with HIV that aren't Alaska Native, and there may not be providers there to provide HIV care. So we will work with those providers, or we'll see those patients when we go out to those areas. We also do provider education on HIV and other STI topics for treatment and prevention. The objectives today are to increase your understanding of STIs and HIV in Alaska, to increase your comfort level in talking with patients about sexually transmitted infections, HIV risk prevention, getting information from patients, and then just to provide you with some helpful resources for when you're doing this work. So I'm going to go over just a little bit of the epidemiology of STIs and HIV. I'll do a little overview of HIV and AIDS 101, talk about taking a sexual history or asking patients kind of some of the difficult questions, and then some different ideas of prevention, testing, and treatment. And then hopefully at the end, we'll have an opportunity for questions. And if you have any questions throughout the presentation, there is somebody monitoring the chat box, and if it's appropriate, feel free to interrupt me and I can clarify something or answer a question. So this data is from 2019, the HIV case rates for Alaska. 2020s will probably come out sometime this spring or summer. There were 69 cases reported to the section of epidemiology at the state in 2019. 27 of those were newly diagnosed in Alaska. So the others were probably originally diagnosed out of state and moved here. But 15% of those were diagnosed with AIDS at the time of their initial diagnosis of HIV. So that means they were diagnosed late in their disease process. One of those people is known to have passed away. 74% were male. About half of those, or a little more than half, were identified their risk factor for HIV as men who have sex with men. 22% were heterosexual. 11% were injection drug users, and just 4% were men who have sex with men and injection drug users. A little less than half were white. 22% were Alaska Native or American Indian, again, overrepresentative of the Alaska Native and American Indian population here in Alaska. And 70% were 34 years of age or younger at the time of their HIV diagnosis. So young people, although we do see this in all ages. And 48% were living in the Anchorage or Mat-Su area at the time of their diagnosis, and the rest were living somewhere else in Alaska. So we do have HIV all over the state. Syphilis in Alaska. Alaska has been experienced a syphilis outbreak. Really started in 2018, but had been increasing in Alaska as it has in the rest of the country for many years. There were 242 cases reported to Alaska in 2019, which was a 112% increase from the year before. Primarily infectious syphilis is what they're seeing. It's increasing in women, and it's increasing in women of childbearing age, which is really worrisome because we worry about women becoming pregnant or being pregnant at the time that they have syphilis, because it can have just detrimental consequences for pregnancies and for babies born with syphilis. 94% of the diagnosed cases were in urban areas of the state, so Anchorage, Fairbanks. And we don't know if that's just that more testing is being done in those areas, because we do know that it does happen in rural areas. Syphilis greatly increases the risk of transmission and acquisition of HIV. And about a third of those people were diagnosed with another sexually transmitted infection at the same time they had syphilis. And again, it was most of the diagnoses were in young people, people age 34 or younger. This just shows the massive increase of syphilis from 2018 to 2019. You can see, and the increase in women. The women is the black bar. So the huge increase in the number of women diagnosed with syphilis. And moving on to chlamydia and gonorrhea, over the last many, many years, chlamydia and gonorrhea, Alaska has had the highest rates in the nation, always in the top 3. I think we've been highest for chlamydia for many years. The state epidemiology department used to do partner notification for both chlamydia and gonorrhea for all cases of it. Unfortunately, just because of the increases in HIV and syphilis, and I believe now COVID, they're not able to follow all the chlamydia and gonorrhea cases. So I think that really falls to providers seeing these patients to educate their patients that test positive for chlamydia or gonorrhea, that they need to make sure that their partners are tested and treated so they don't get these infections back again. Moving on to HIV, just an overview. HIV is the virus, AIDS is the disease. So you cannot have AIDS without having HIV, but just because you have HIV, it does not mean that you have AIDS. What HIV does is the HIV virus attacks the immune system. It enters the CD4 cells and kills the CD4 cells and replicates in the process of doing that. So it causes dysregulation to the immune system over time while replicating virus. This is another slide explaining the stages of HIV. Acute HIV is 2 to 4 weeks after infection. Oftentimes people will experience flu-like symptoms. They may feel really run down. They may have swollen lymph nodes. They may have a really sore throat. They may have some nausea, vomiting, diarrhea. They may seek care during that time. They may even be tested for HIV during that time, and it's possible that they could have a negative test. Or they may seek care and be tested for flu or for strep throat. Later on, people move into what's called the clinical latency period. They can still transmit it if they're not on HIV medications to control their virus. And again, if they're not taking medication, it will cause inflammation in their body, and it will lead just to more chronic health problems later on. And this period of time can last years or even decades. And then stage 3 is AIDS, and that's when the immune system is damaged from the virus. People are more likely to develop other illnesses, may become symptomatic, and they may be more contagious if they're not on HIV medications. This just shows some of the symptoms of acute infection, which I mentioned before. The symptoms are caused by the body's response to the virus. The body's developing antibodies trying to fight off the virus. So that's why the swollen lymph nodes, maybe a fever, a rash. A rash and a fever in adults is a red flag and should make people think about either syphilis or HIV, and be sure to test for both of those things. Just another slide explaining kind of the middle period between acute infection and AIDS diagnosis. This is when HIV is slowly taking over in the CD4 cells, and this can go on for many, many, many years. It is important to know, though, that people that are taking medication for HIV, antiretroviral therapy, the right way, which is taking it every day, can live long, healthy lives just a few years shorter than the normal lifespan. I always tell our patients that smoking will actually take off many more years of life than HIV will. And this just shows some of the things that can happen if someone's not taking their medications and it moves to AIDS. They can end up with encephalitis, meningitis, and it can lots of pneumonias, tumors, cancers, and different viruses and bacteria can take over. I've got a slide that lists out all the opportunistic illnesses that would indicate an AIDS diagnosis. This is the list. That if anyone with HIV develops any of these things, it indicates that they have a very weakened immune system and would in turn be an AIDS diagnosis. And unfortunately, even though we have great medications for HIV, we do still see patients that really struggle with taking their medications every day, or just have a lifestyle that they're not able to, despite a lot of support. Or maybe some mental illness, and they just don't feel it's necessary to take their medications. And we do have patients that have been diagnosed and suffer from some of these things. Our goal with treating HIV and managing HIV is to increase the patient's CD4 count so that they can fight infections and have a normal immune system, and to keep their viral load the HIV viral load in their body low. Number one, to keep them healthier, because the more virus that they have circulating in their body, the more inflammation it causes, and it leads to more chronic health problems, heart disease, things like that for them, but also so that they don't transmit it to others. And I'll talk more about that, because if people are undetectable, they are untransmissible in most cases. This slide just shows the natural history of HIV. And this would be, if someone were not taking medication. So if they were diagnosed at year 0 with an acute infection, and just the time. And again, so about 10 years to developing AIDS, but it can go faster depending on how healthy people are and what other things that may be affecting their body. Drugs, alcohol, things like that can certainly speed up the process to AIDS. The good news is that we have less new diagnoses in the US every year. And more good news is that people are living longer with HIV. So we have more people living longer with HIV, but less new diagnoses. And like I mentioned before, the lifespan for people living with HIV who take their medications daily is very close to a normal lifespan. And so the number of new infections is finally decreasing, although slowly. But people are living longer and healthier lives, and that's really good news. This is a slide of our HIV care continuum in Alaska, and the numbers have changed a little bit since then, but it was estimated in 2018 that we had about 679 people living with HIV in Alaska. Of those, 635 were linked to care and engaged in medical care. And that means that they had at least one medical visit for HIV within the year. And then 89% of those were engaged in care. And that means that they had labs and were virally suppressed. And so they were consistently taking their HIV medications. Overall in Alaska, I think we do a really good job, and that's not just us, but that's other providers here in the state and public health. And I think we work really well together to make sure that people with HIV are diagnosed, and that we do warm handoffs to make sure that people are directed to appropriate HIV care. And then when people fall out of care, we work really hard to try to get them back in care and figure out what support do they need to re-engage and to stay in care, and what support do they need to make it to their medical appointments and to take their HIV medications. So part of prevention is testing, and routine screening is recommended for HIV. Different organizations recommend different age groups between 15 to 65 that everybody should be tested at least once for HIV. Some say 13 to 65. Testing is voluntary. Permission, just like any other medical test, is required from the patient, but written consent is not required, and prevention counseling is not required in conjunction with HIV screening. These are other, CDC recommends opt-out HIV testing, that we offer it to everyone. Certainly if people are initiating treatment for TB, if they've got other sexually transmitted infections, it's always, pregnant women are always tested for HIV. And it is reimbursable with insurance and Medicare and Medicaid. So why do we care about finding HIV? Alaska is a low prevalence state, but low prevalence does not mean no prevalence. And most of the people diagnosed with HIV, when we look back at their charts, we've seen multiple missed opportunities where they could have been diagnosed. Like maybe they came in and had flu-like symptoms. Maybe they came in and were diagnosed with syphilis but didn't get an HIV test. Maybe they came in concerned about a partner that had an STD, and or they had multiple STDs over the years and never been tested for HIV. So anybody, we recommend routine screening, but then annual or even more frequent screening for people at risk for HIV. 10 to 50% of HIV transmissions occur early in infection prior to diagnosis. So what that statement means is that most people that don't know that they have HIV are responsible for most of the infections. I think we do see that once people know that they have something that they may transmit to other people, they don't want to do that. So we want to avert new transmissions. And then the cost of care for late diagnosis is huge, not just financially, but for the person who's diagnosed. If they're diagnosed late in the disease, they can be very, very, very sick. This is another slide just showing that people that are unaware of their status, their HIV diagnosis, and people who are not in care or not on medications are responsible for about 80% of new infections. Another slide just demonstrating that 15% of people who don't know they have HIV estimated to be responsible for about 38% of new infections. 23% who knew they had HIV but weren't in care, meaning they weren't taking medications, responsible for another huge chunk of infections. And then it shows down here, this is the exciting part, 51% of the people that are taking their HIV medication and virally suppressed are not responsible for any infections. So we have learned that when people are undetectable, consistently taking their HIV medications, they are untransmissible. So we want to diagnose people as early as we can. We want to treat HIV quickly. As soon as people are diagnosed, we start talking about treatment. In the olden days, 10, 15 years ago, we would wait until people's CD4 counts got to certain levels before offering them treatment for HIV. That has changed just to the opposite now. Now, as soon as people are diagnosed, medications are much easier to take, much less side effects. And by treating people early, we protect people that are at risk and avert new infections. So our screening recommendations are screen everyone between the ages of 13, and we don't stop at 65. We have had new diagnoses in people that are older than 65. And we recommend rescreening at least annually or even more often people who we know have risk factors, men who have sex with other men and have multiple partners, people who use injection drugs, and then HRH stands for high risk heterosexual. So that would be a patient who has sex maybe with someone who's HIV positive, somebody who has sex with someone who uses injection drugs, or a heterosexual person who has sex with a partner who's HIV positive. Consider testing people who have multiple sexual partners, if they have a history of substance abuse or are currently using, mental illness, and then any diagnosis of other sexually transmitted infections, hepatitis C or recurrent sexually transmitted infections. People who report sex when they travel, or people who report transactional sex, and that's could be taking sex for money or drugs, or also what we call survival sex, people that may be having sex for a place to stay or for food. And then certainly with each pregnancy, people are tested for HIV. Some common barriers that we've seen to HIV screening being provided is providers' fear of offending patients by offering the test. Their belief that the population that they see doesn't include high-risk patients, that they don't see patients that do those things. Feeling like they have the lack of time to offer the test and counsel the patients, and concerns about funding or reimbursement issues to cover the cost of testing. And really, we don't need to do a whole lot of counseling. Certainly patients need to be notified that they're being tested for HIV, but we don't have to have a long counseling session with people. It's nice to have the time to do that, but it is not necessary. And then funding and reimbursement is no longer an issue because insurance companies and Medicare and Medicaid do pay for HIV screening. The most common HIV test that's used in clinical settings is a 4th generation test. And it's a screening test. And it's an antigen antibody test. And if that's positive, it's followed up to differentiate between HIV-1 and HIV-2. And primarily in the US, we see HIV-1. And if that is negative, it is followed up with an HIV viral load to confirm that test. So it's got several steps along the way to confirm an HIV diagnosis. There are rapid tests, and I don't have any slides of that in this presentation, but I will just talk a little bit about it. There are rapid tests that are used in non-clinical settings that can be used in patients' homes, and that can be used for outreach. And those are just antibody tests. Those do require a follow-up confirmatory test. So if that's positive, it's considered a preliminary positive test, and that does need to be followed up with a blood test for confirmation. This is just another slide just to kind of show window period for laboratory diagnosis of HIV infection. So it can take the HIV antibody, that's the green line, about a month to peak as far as for that to be detected. And then viral load is much sooner, anywhere from 7 to 10 days. And then there's some antigens in there that are in between there. So the test looks at all of those things. But we recommend that people get tested about 4 to 6 weeks after an exposure that they're concerned about, and then that they follow up at 3 months just for any outliers. But if it were myself, I would feel very comfortable with the test, about 6 weeks after an exposure. You can see the days that it really peaks following HIV acquisition. So I'm going to talk about treatment as prevention, because treating patients for HIV does prevent it from being transmitted to other people. And then there's something called PrEP, pre-exposure prophylaxis, which prevents people from acquiring HIV. So and I'll talk a little bit more about that further on, and about who should take PrEP and treatment. So I mentioned earlier, we do start people that are diagnosed with HIV. We like to start them right away. Sometimes they're even started on the day that they find out about their HIV diagnosis. Typically, when someone's first diagnosed, we do get a whole bunch of lab tests, because we want to see kind of where they're at with things. We want to see what their CD4 count is. Is it high or low? Are they kind of new in this infection, or have they maybe had it for a while? We also want to get a genotype, an HIV genotype, which will give us an idea of what medications may work best for them, because unfortunately, HIV virus does develop some resistance to medication. So if they've acquired a resistant strain, we may want to use certain medications. But we try to start people right away, and really everybody in Alaska has the opportunity to take HIV medications. There's programs for people that don't have funds or health insurance to cover HIV medications. Alaska has an AIDS drug assistance program to help those people pay for medication. So there's really no reason anyone living in Alaska who wants to take HIV medications cannot take HIV medications. This just is a slide that shows what it used to be like and what it's like today. So we're really fortunate today. Most of our patients, not all, most can take one pill once a day, and the pills are getting smaller and smaller. And they have very few side effects. 10, 15, 20 years ago, people had to take a handful of pills, what shows on the left-hand side of this slide. And they may have to take some pills with food, some pills without food. They may have to refrigerate some, others may have to be at room temperature. Some couldn't be taken with other medications. Some had to be taken before food, or, so many hours or after, some twice a day. So it's gotten much, much easier. We certainly still have patients that do have to take multiple medications during the day, and that's just because they've unfortunately developed some resistance. But most people can take one pill once a day, and that's exciting. Sometimes the biggest barrier, the biggest issue for our patients is just being overwhelmed with life and other things going on. This is a patient that we have tried everything with to try to get him to stay on his medications. We've done home visits. You can tell we filled pill boxes. We got Medisets for him, and he came in one day and brought all his medications, months and months worth of his medications, and just said, "I just feel overwhelmed." And I think he had, lots of other things going on in his life, and he has struggled for many years on taking his medications, and unfortunately, he's still struggling and still having a really hard time with it. And we work really hard to identify what it is that's not working for our patients, what's getting in the way of them taking their medications, to try to get them to take them every day, since it's so important to their health. So taking HIV medications reduces the morbidity and mortality by suppressing viral replication. The virus it's not able to make more virus, and so it's not going into the CD4 cells and killing CD4 cells. So it improves immune function, makes people less likely to get other infections and illnesses, and it reduces resistance to HIV medications, because it's possible somebody can develop resistance to one medication, but because other medications are so similar, it may wipe out, several medications that they're no longer able to use to treat HIV. And it improves the quality of life for those people that are living with HIV and AIDS, and prevents, slows down the development of chronic illnesses. And I'm going to talk a little bit about PrEP, and I'll just mention PEP, but I'll start with PrEP. PrEP stands for pre-exposure prophylaxis. PrEP is something that people can take before they are exposed to HIV to prevent them acquiring HIV. So PrEP is something that someone without HIV takes to avoid getting HIV. PEP stands for post-exposure prophylaxis. So this is something someone would take that's HIV negative after they've been exposed to HIV. An example of this would be in a sexual assault or a needle stick. The important thing about PEP, post-exposure prophylaxis, is the timing. You have up to 72 hours to start it, and it's usually taken for 28 days. It's a regimen of 2 pills. It's 3 drugs taken over 28 days, but it is really important. It is much more effective started sooner. So we recommend that anybody who has a needle stick or has a sexual assault start PEP within hours of that incident. So if someone is working in a setting where they get a needle injury, you don't want to wait until the end of your shift to report the needle stick and then go and seek post-exposure prophylaxis. You want to do that right away. It's been shown over time that the efficacy of it really drops off the hours and hours you get away from that incident. And then PrEP is pre-exposure prophylaxis, and the opposite of that is taking PrEP before being exposed to HIV. So this is not my slides. I'm just looking at some of the things written on here, but it means you cannot just ignore the 3 the statements on the top of it. But PrEP, the campaign for that is U equals U. So undetectable equals untransmissible. And talk a little bit about U equals U. So U is, I mentioned, undetectable equals untransmissible. So that's patients that have HIV taking their medications, having an undetectable viral load, they cannot transmit it to other people. It can reduce HIV-related stigma. When we've told patients, this is new probably within the last 4 or 5 years, that we've learned that undetectable viral loads of our patients, they do not transmit it to other people. And I think some, partners have known this over time, where they've been in discordant relationships where one partner is positive and the other partner is negative. It can reduce HIV-related stigma and improve mental and emotional health for people living with HIV. Let's see here. So back to PrEP. Sorry about that. Things got a little bit out of order. It's a prevention strategy in which a high-risk individual takes medication. There's 2 medications approved for it. One is called Truvada and one is called Descovy. And they take that daily. It first became available in 2012, and then they have this medication in their system so that when they are exposed to HIV, they don't get it, assuming they're exposed to HIV through their high-risk interactions. It is a prescription medication. It does require some testing prior to getting a prescription for it. Number one, we want to make sure that people are HIV negative before they start the medication, because it's not a complete, it is a medication that's used for HIV, but it's not a complete treatment. So if it were given to someone that had HIV, they could potentially develop some resistance to HIV. And then we want to make sure we monitor their kidney functions and make sure that they just, they're not having any kidney problems from taking the medication. So we usually get labs before someone starts it, and then we have them come back about a month after and just check their kidney function, make sure they're doing okay taking the medication, not having any side effects, and most people do fine with it. And then we get labs every 3 months, and that includes an HIV test just to make sure they haven't acquired HIV during that time, and monitor their kidneys. So when to consider PrEP for patients is when someone's at risk for HIV. And, substantial risk, people don't always share their risks with us. So I think if someone's coming in and asking for PrEP, that is a good enough reason to explore it and offer it to them if they want it, even if they're not identifying what you may consider a significant risk. It could be someone who's in a discordant relationship, a negative patient who's with a partner who's positive. It could be someone who's not in a mutually monogamous relationship. They have multiple partners, someone who has frequent STIs, someone who's sexually active with other high-risk people, somebody maybe using injection drugs, or those engaging in any transactional sex. But certainly I think that PrEP should really be considered for anyone who is who comes in asking for it, because I think that oftentimes people don't always share their risks with us. PrEP is a daily medication at this point that people take every day. And then once they're exposed to HIV, they've already got the medication in their bloodstream so that they do not acquire HIV. There is some ways to take PrEP that are a little bit different, where people can take it before they have a known exposure, but that's a little trickier at figuring that out with a provider, and more research is being done on that. As far as like, if someone knows they're going on vacation and they know they're going to be having sex, they can take it for a few days prior and then take it so many days after exposure. But really the simplest way is for people to take it every day. And so just, HIV is transmitted through sex, through injection drugs. It can also be transmitted from mother to baby, but there's great ways to prevent that from happening, from moms to babies, making sure that pregnant women that have HIV are taking HIV medications throughout their pregnancy greatly reduces the risk of transmitting it to their baby. And then now we know that people that are taking their HIV medications regularly don't transmit it to their sex partners. And we also want to, we spend a lot of time counseling patients with HIV on how important it is that they take their medications every day. And there are barriers, and I mentioned before, mental illness, substance abuse really get in the way of people taking their medications every day. And some people just get sick and tired of taking a medication every day. And many, many years ago, people used to take what they called drug holidays, just to take a break. That is not at all recommended anymore, just because we know how much the HIV virus can cause inflammation. And we know then that they're also infectious to other people. So it's not recommended that people take breaks. But people may stop their HIV medications when they're using drugs or drinking. We've worked with our patients to identify times of the day that they're able to take them, even if they do drink every day. We have patients that are homeless and do drink every day, but successfully take their medications every day. And that's demonstrated by them having undetectable viral loads. And they've just decided for them that it's easiest if they take it first thing when they wake up in the morning before they start drinking. They just know that they need to take it before 11 o'clock in the morning. We have other patients that stop taking their medications when family comes into town, because they don't want family to see their bottles of medication and figure out what they may be taking their medications for.
Lisa, we do actually have a couple of questions, and now might be a good time to go ahead and start talking about some of those before we move into sexual history. So we had a question from Maria. And Maria, if you want to go ahead and unmute here in a second and make sure that I'm capturing what you put in chat correctly. She was wondering about something specific in regards to syphilis being a big risk factor in contracting HIV. Is it just that co-occurring correlation? In other words, to understand the correlation of syphilis and HIV, this is a correlational relationship and not a causational one, correct?
Syphilis increases the risk of HIV transmission because well, the behavior is the same through sex, but also syphilis is an open sore. So it's a great way for HIV to get into the body. So the syphilis sore is just an access point for the HIV virus to get into the body, just like herpes would be, or any open sore or open cut. So that's the, but then also the behaviors go along the same with syphilis as far as sexual contact, where body fluids that contain HIV or syphilis can be transmitted the same way. Does that answer it?
Maria says, gotcha. Thanks for answering.
Good question.
I understand
Thank
more
you.
now. Okay. And we have one from Angela Lee. She wants to know, Lisa, what your thoughts are about a cure for those with a CD4 cell count of 1,500.
A cure?
Yes.
Well, unfortunately, right now, there is no cure for HIV. I'm hopeful that I'll see it at some point while I'm still working in HIV. But right now, there is no cure.
And Angela, if you have a
and, you know,
follow-up.
a CD4 count of 1,500 is a good, healthy CD4 count, but people can still be infected with HIV.
Okay. Angela, if you have a follow-up question to that, you can go ahead and chat me. And then Lisa, we do have a process question from Jonathan. He's wondering what role we are working with AK Correctional Systems and how it pertains to HIV prevalence inside of DOC. Wondering about our testing procedures inside of DOC, linkage to care, and harm reduction strategies. I did message Jonathan back that was a pretty lengthy conversation and that we would be happy to talk to him about processes. But Lisa, if you do want to touch on maybe some of the relationship that we do have working with DOC when our clients go into their care.
Well, I think it's a great question, just because we really do like to work with DOC, because we do have our patients, some of our patients do go in and out of Department of Corrections. And I think overall we have a good working relationship with them, where they will let us know when our patients are there, make sure that they've got the current treatment correct for our patients, so they get the right medications while they're in jail. We don't do any testing in DOC right now. Public Health may. Certainly we encourage DOC to do testing for HIV, for all STDs when people go in, and we're there to support patients when they get out. We really, it really depends on the facility, it seems like, and the people that are working in it, as far as the follow-up we have for our patients once they leave DOC. But we like to have contact with them before, so we can set up an appointment. So I think it's really nice when patients know that they're getting out and they know they have an appointment with us, because it's really, sometimes we see patients released with no meds. Sometimes we see them released with 5 days of meds, and sometimes we see them released with a month, but just to have a plan in place so they don't have any gaps in care. So I'd love to talk to him more about that afterwards.
Okay, that's awesome, Lisa. And I made sure that Jonathan had our contact information so that we can have an in-depth conversation about that. And now we are up to date on our content questions. So you can go ahead, Lisa.
Okay, so this is just moving on kind of how to ask personal questions, how to take a sexual history, because it can be really challenging and still is for me, even though I've been doing it for many, many years. So what do we do about the discomfort in asking some of these questions? I think educating ourselves, like we all are today, just learning more about HIV and STIs in our community, knowing that it's out there, knowing that HIV is out there, knowing that we have just the highest rates of chlamydia and gonorrhea, because we can share that with our patients when we're asking them these questions. It gives us a reason to be assessing our patients for these. So, and then practicing these conversations with each other, with our patients, learning things from things that go well and learning things from things that don't go well, and learning from each other on how we ask questions, because I think we can always learn from each other. So when interviewing patients or just taking a sexual history, using normalizing language, patients may come in and not know the medical lingo that we use, but it's an opportunity for education. Remembering to be non-judgmental, reminding patients that we ask our patients these questions. We ask them all these questions. There's nothing about them. There's nothing about the way they look or the way they're dressed that's making us ask them these questions. Trying to ask open-ended questions. Not all questions can be open-ended questions, but trying to as much as we can. And not assuming anything, even based on maybe what's in the record beforehand, or even from a previous interaction, continuing to ask the same questions over again, even though you've seen a patient before. Sometimes patients will get more comfortable with us and will share things at subsequent visits, Or it's possible that things have changed for the patient in the time since you've seen them. If things aren't making sense, repeat questions and ask them another way. And then I think starting with the easy questions first, starting with less invasive questions and moving on to more invasive questions. So trying to set the patient at ease and yourself, talking to patients in private. And so that may be asking a significant other or a parent to leave the room, reassuring the patient of confidentiality, but also knowing the limits of this. For an example for this is any abuse that you would have to report, like sexual abuse of a minor. So knowing that limit, and then maybe how you're going to share that back with the patient that you have to do that. These can be difficult interactions, especially if you have relationships with patients outside of the clinic, which we often do, especially in the smaller communities in Alaska. If you do know somebody and someone is uncomfortable seeing you, if it's an option for them to see someone in the clinic that they don't know outside the clinic, I think that's great. That's often not the case in busy clinics or clinics, that are just staffed by just a few people. But if it is, that's nice. And acknowledging the discomfort. Look, I know we know each other from outside. I know our kids go to school together, or we're, in some instances, people are even related in provider-patient relationships. Letting them know that anything, is confidential. It's not going to be shared outside those walls. And so trying to find out why they're there without really asking them why. What brings them into the clinic today? Are they having symptoms? Did someone who tested positive for a sexually transmitted infection tell them to come in? Did public health tell them to come in? Are they worried? Well, I'll have patients call me on the phone or come in and say, I just want to be tested for everything. Well, there's really no place you can go or any kind of medical visit where you can just be tested for everything. And in my experience, when someone comes in saying that they just want to be tested for everything, it usually means that they're concerned about a sexually transmitted infection. So it may just be kind of narrowing down to what they're really worried about. I do have beginning history of present illness in here, and that's for the health aides, because that's where they start, and that's a great way to start with the less invasive to more invasive questions. And so clarify with them, I mentioned this on the previous slide, I just want to be tested. Well, tested for sexually transmitted infections. Has something happened that they're worried about? Did someone tell them that they should be tested? And being specific, finding out more. If a patient states, I have a sore, find out more about it. Where exactly is it? How long have they had it? Is there something that they do that they put on it that makes it feel better, something that makes it feel worse? Have they ever had it before? Does it come and go? Have they noticed any sores like that on any of their people that they've had sex with? That's going to give you more information on the diagnosis of what it is. So asking more questions to find out more. Sometimes people are so uncomfortable talking about their risk for sexuality and sexually transmitted infections. They try to keep it brief and try to answer with just yes or no questions. And using your questions as an opportunity to educate. So, asking about the number of sex partners people have had, and then telling them back, well, the more people that you have sex with, that increases your risk for sexually transmitted infections. I want to make sure that you get tested for the things that you need to be tested for. Because these questions don't have to be, there's an opportunity to ask patients these questions outside of just a visit for sexually transmitted infections. It can be at well visits, annual visits, physical visits for teens that may give you an indication that they need to be tested, even though it's not a visit that they came in concerned about STDs, especially with young people. Asking about when you have sex, do you have sex with men, women, or both? And even try to make this, kind of more open-ended or to get more information. When is the last time that you had sex with a woman? When is the last time that you had sex with a man? Just to make it any answer that they have is an acceptable answer. And then educating them. Men who have sex with men are at an increased risk for gonorrhea, HIV, and syphilis. We just see that more in those populations. Then we need to ask about sites of their body that they use for sex. And I think there's a variety of ways to do this. When you have sex, do you have oral sex? But I think even better than that, that's written up there, is when is the last time you had oral sex? Or when is the last time somebody put something in your mouth for sex? When is the last time somebody put a penis in your mouth? When is the last time somebody put a penis in your rectum or anus? Some people will use giving or receiving or top or bottom, but I think sometimes that can get confusing depending on who you're talking to, and you may just have to really break it down to the body parts that are used. I've also found it works just to walk in with all the swabs that you have into the exam room and just say, oh, I brought all the swabs in to test for all these places. Should we get your throat? And most of the time, patients will take the swabs to the bathroom and do their self swabs for the vaginal and anal swabs. And we can educate them that they can get different infections in different parts of their body. If a patient comes in and we only test them, they come in and we're going to test them for chlamydia and gonorrhea and we only test them with a urine test, that's not going to let us know whether they have it in their throat or their rectum. So they may walk out thinking they've been tested for STDs and still have an infection that's not diagnosed or treated. And asking about condoms. And patients often, they'll tell us what they think that we want to hear. So give them an out. Have you had any problems with them breaking or falling off? And just reminding them that used every time and correctly, they can help prevent sexually transmitted infections and pregnancy, but they do not protect from all sexually transmitted infections. You know, genital warts, herpes, and even syphilis could still be transmitted with condoms because of direct skin-to-skin contact. So, and then asking about sex and drugs. The last time you had sex, were you drinking or using drugs? These things make people do things that they may not otherwise do. They may have sex with someone they wouldn't otherwise have sex with. They may not use a condom. They may have multiple partners. So identifying those things so that in the future that they can kind of plan how to reduce their risk if they're using or drinking. And I do have a condom demonstration video here that I think is really good and really matter of fact, and even just for providers to see, just to be able to go through and show all the steps to a patient. So I am going to try to show this, and maybe someone can let me know that you can hear it.
This is a male condom demonstration. I have a selection of condoms here, and for this demonstration we're going to choose a banana flavored male condom. The reason they have flavored condoms is to encourage people to use condoms for oral sex. It's important to think about using condoms to provide protection from sexually transmitted infections during oral sex as well as during sexual intercourse. So there's 3 things that we want to check before we even open a male condom. One is the expiry date. Condoms are made of a material that actually break down over time, so it's important to check the expiry date. It would be electronically printed on each condom, and this one has not expired yet, so that would be good to use today. The second thing we want to check for is that there's air in the package. We want to push on the package and make sure we feel a pocket of air. And this is telling us that there's no holes in the package and that it hasn't been damaged. We also then want to check to make sure we know what it's made out of. This one is made of latex. We want it to be made of latex or polyurethane, and those are the 2 materials we know provide protection from sexually transmitted infections as well as HIV. Not all condoms provide protection from HIV, for example, like sheepskin condoms. We're then ready to open the condom. We want to push it over to one side and then rip down the other side. And we're doing this so that we don't damage the condom. So rip down the side, be careful of fingernails, be careful of jewelry, and don't use your teeth or scissors to ever open a condom. This condom has a funny shaped tip. It's called the reservoir, and this is the space to collect semen. It's important there is a space at the tip of the condom to collect semen, otherwise it could really increase the chance of it breaking. Now there is a right way and a wrong way to put on a male condom. The right way is if you look down on the top of the condom, there's a crease between the condom and the roll. If it was the wrong way, it would just bump over the condom, and that would be not the right way to put it on. It would just simply roll over the roll. So we want to take the condom and place it on the tip of an erect penis, and we're going to pinch the tip. And we're pinching the tip for 2 reasons. One is to make sure there is that space of the reservoir. The other is to make sure there's no air in the condom. That can increase the chance of it breaking. We'll keep it pinched and roll the condom down. And we would do this with 2 hands. So it would sort of look like this. Pinch and roll with 2 hands. Now, both partners are ready for sexual activity. After ejaculation, which means semen is going to come out of the penis, the erection would slowly start to go away. And that means the condom could slip off really easily. So after ejaculation, before the erection goes away, you'd want to hold onto the condom and pull out from the body. Then carefully pull the condom off and tie it in a knot. And we'd want to discard it in the garbage and not in a toilet because it can clog your toilet.
Okay, I think that's a good video. And I think it's just nice to review that every once in a while, to be able to share that with patients and know how to tell them all the steps with using condoms, from the expiration date to storage, and as far as not getting them on backwards as well and reusing them. So really important in working with patients is exploring their risk factors. Are they only having sex when they're drinking or using drugs? What can they do to decrease those things, or what can they do around those things that may make them less likely to engage in risky sex? Maybe have friends with them, maybe make sure that they take condoms with them, or maybe a PrEP prescription is what's appropriate for them. And are they in a violent or abusive relationship? They may not be able to negotiate safe sex. They may not be able to say no or to negotiate condom use. So for someone in a violent or abusive relationship, their prevention really may be, or their risk reduction really may be, frequent or routine testing, getting tested for HIV and sexually transmitted infections every few months. We might find it frustrating to see patients keep coming in, getting tested for the same things and not changing, but we don't really know what's going on in their relationship. And so their risk reduction may be getting tested frequently, so that if they do have something, it's diagnosed and treated early. Do they have multiple partners? Making sure that they're aware that multiple partners does increase their risk for sexually transmitted infections, including HIV. Serial monogamy, explaining that to young people, making sure that, even if they're having sex with just one person for a period of time, just one partner for 2 or 3 months, and then moving on and having another partner, anything from a previous relationship can be brought into a future relationship. Are they having sex for money, drugs, or alcohol, or a place to stay? And then have they traveled recently, and did they have sex? I mentioned before, Alaskans travel a lot. We do see a lot of patients coming into Anchorage, or patients going back out to rural areas, and people, may take things that they've acquired when they've come into Anchorage, like sexually transmitted infections or HIV, and spread it to rural areas. And then do they meet partners online? I think this is the biggest risk for sexually transmitted infections and HIV, especially with syphilis and HIV. People that are having a lot of sex with a lot of anonymous partners and over short periods of time really increases their risk. And there are a whole load of different apps where people can use to meet sex partners online, wherever they're at. So exploring all of those things and educating patients on them. Just a cartoon partway through, just for a little bit of a break. And then another one, just, it does require asking a lot of questions, and sometimes we do feel like we get a lot of information. And if we do have patients that are reluctant to share risks with us, or don't, want to answer questions, still offering the testing is really important. And maybe later on people will be more likely to share information, but the important thing is that they are still able to be tested. So who do we want to test? We want to test anyone who is having sex, and we need to ask, and I encourage you not to ask if they are sexually active, but ask if they're having sex. And we want to test them at least once a year, or any times they've changed a partner, or any times they're symptomatic, or any times they've been told that they need to come in and get tested. And we want to do Aptima testing for chlamydia and for gonorrhea. That's a urine test for men, and then it's a vaginal swab for women. The self-collected vaginal swabs have shown to be better for women than the urine test. And then let people self-collect the swabs for the rectum and for the vagina. Most of the time I'll do the throat swab for patients. They don't necessarily like to do that themselves. And then make sure that anybody who does have a diagnosis of chlamydia or gonorrhea, they should be retested, and they should be retested not because of treatment failure, but really because people get re-exposed from an untreated partner. And guidelines for the treatment of gonorrhea, the CDC STD treatment guidelines have recently changed. So the treatment now for gonorrhea is 500 milligrams of Rocephin with 7 days of doxycycline instead of Zithromax. So just be sure that people are up on the, people that are providing treatment for STDs are up on the new treatment guidelines as well. And that's just because of resistance to antibiotics, that those have increased. And then being aware of expedited partner delivered therapy. It is legal in Alaska for providers to provide treatment for partners without necessarily seeing the partners of the patients that they're seeing. So asking patients about how many partners that they have, and then providing doses of medication specifically for chlamydia. There are instances, with gonorrhea and other things that's not possible, but to explore with the patient that's positive how their partners are going to get tested and treated, because that's an important part of their care and them not getting it back again. So sharing things back once we've had these conversations with our patients, sharing back with them, from what you're telling me, it does sound like you're at risk. And what specific it is that they're doing that puts them at risk, and what you can do to decrease their risk, whether that's, I really think that PrEP is a good idea. How can we get you started on PrEP? Is that something that you'd want to do? Are you able to take a pill once a day? Or if they don't want to do that, can they use condoms more? Can they decrease the number of partners that they have? Or are they interested in alcohol or drug abuse treatment? So encouraging them and supporting them. I'm really glad that you came in today, or I'm really glad that you came in, even if the sore that you have is not caused by a sexually transmitted infection, just knowing that will put you at ease. Or if it is, just getting it appropriately diagnosed and treated is important so that you can move on. It makes people feel better. And just remembering, I've talked about this on previous slides, just urine only checks for the urethral and vaginal infections. So we miss a whole bunch of infections if we're only doing urine tests or vaginal tests. We need to think about extragenital testing for chlamydia and gonorrhea, throats and rectums. So that's the reason for asking people about the parts of their body that they use for sex. Patients aren't willing to talk to you about that, just offer them the testing for it anyways. And remembering that women also get extragenital STIs, so asking about and offering testing for throats and rectums as well. So always offer it anyways. And having a sexually transmitted infection does increase the acquisition and transmission of HIV about 3 to 5 times. And like the syphilis question earlier, but chlamydia and gonorrhea as well, just because it's the body's immune response. It can be irritating to the cervix or other genital tissue, which does make it more likely that HIV is transmitted if HIV is present. This is just some posters from the University of Madison Clinic on self-collection of swabs for chlamydia and gonorrhea, and these are available to clinics if you contact them, and the email address is here where you can get free posters for yourself so that patients can self-collect them. I find that most people don't want to do their own throat swab. This slide is for a national HIV curriculum put on by the University of Washington, and it's free CEUs. It covers HIV diagnosis and care. It's also got things, there is one also for sexually transmitted infections. It's really easy to use. It monitors your learning, and it's got a lot of good information in it. So it's if you're interested in more HIV and STI topics, and it's updated. And this just kind of shows how it's used, and you can get CNEs and CMEs. So for HIV and STDs. This is the I Know Mine website, and I believe it's changed a little bit just in how it looks from when this screenshot of it was taken, but this is a website put on by ANTHC, and it has a whole host of topics, which is great for young people and also parents of young people, relationship safety, birth control, sexually transmitted infections. It has the option to go in and ask questions. You can also link to ordering things for your clinics as far as brochures, posters. You can also, it links to the I Want the Kit website, which I'll go to here in just a second, which is at-home STI testing. It also links to a way to order an at-home HIV test. These are some of the older promotional materials. I'm sure that this has been updated on the website. This is the iwantthe.kit.org. And you can either go directly to I Want the Kit just by typing in I Want the Kit, or through the I Know Mine website. And this is ANTHC provides the service to anyone living in the state of Alaska 13 years of age or older, they can order a test kit online. It's very simple. You do have to have internet access because you have to go in and create an account, but it will mail a kit to your home or your post office box. It comes in a manila envelope. It doesn't have anything on the outside that says what it is. There's no cost for this, and the postage is prepaid back to the lab. It takes a few days for it to, once ordering it, for it to get to people, and then probably a few days back. Probably the turnaround time is probably 10 days on a good day with no holidays and no breakdowns in the postal service. Sometimes it can take up to 2 weeks, for more rural areas. So if someone's having symptoms, I don't encourage them to use this. If someone has symptoms, I encourage them to go to the closest healthcare provider, because if someone's having symptoms, we want to make sure they get diagnosed early so that they don't have any consequences like pelvic inflammatory disease or epididymitis or anything from a sexually transmitted infection. But if it's just a screening test, I think this is a great resource for people that may be uncomfortable or it's just not convenient for them to go in and get tested for STDs. ANTHC's also on the I Know Mine site has started offering rapid HIV tests for at-home use, and we just started that within the last month, and that's people can go online and request an HIV or a quick test, and it comes with instructions on how to use the test. And we are following up with phone calls with those patients, and so far it's all been really positive. For the I Want the Kit for the chlamydia and gonorrhea, we do follow up with any of the positives. The positives are reported to the state because that's mandatory for any positive chlamydia or gonorrhea. For women, it also does check for trichomonas. And then we make sure that people know where they can get treatment. So regardless of where they are in the state, we'll work with them so that they get treated for that. So things that you can do, I don't know the setting that everybody that's listening in is on, but you can encourage HIV testing for people that you're working with, encourage sexually transmitted infection testing, educate patients on pre-exposure prophylaxis, that it's out there, that it's available. I should mention insurances and Medicaid are covering PrEP. If you know patients or people with HIV, if you have taken care of patients with HIV, assess their adherence to their HIV medications. Are they taking them every day? Are there things that are getting in the way of them taking them every day? Make sure that patients living with HIV and AIDS are connected to services that can help them. And then take sexual risk histories, and including alcohol, substance abuse. And you're welcome to call us with questions anytime. That's our main line number, or to let us know if you're working in a hospital setting or clinic setting, to let us know that someone's being seen or has been admitted. And we don't always know that, and we'd like to know that to check up on our patients. Or if you're seeing someone that's been out of care for a while, we'd love to help get them back into care. The 4A's is a local AIDS assistance agency that we work really closely with. They're here in Anchorage, and they provide social service support for patients living with HIV throughout the state. There's also another agency, and I don't have their slide, that we work really closely with and does just as good a work, and it's IAA, the Interior AIDS Association out of Fairbanks, and they provide similar services for patients in the Fairbanks area. The 4A's also and the IAA both have needle exchange programs with their agencies, and those I believe have changed a little bit because of COVID, but should have updated information on their websites. Additional services there. So, and just a reminder, March 20th is National Native HIV/AIDS Awareness Day. In years past, before last March, we sometimes did tabling events or different events for HIV. COVID has changed that, so I don't know what we'll be doing this year, but it's in the past been a day to reach out for people living with HIV, also to remind people about testing for HIV, get people to share their stories. About HIV and AIDS, and think about the impact on individuals and communities living with HIV. So again, just resources, how to reach us. Here, we also got Dr. Wesley on there. He's in private practice here in Anchorage and sees patients with HIV. He also sees pediatric patients here at Alaska Native Medical Center for Infectious Disease. And then just the opportunity for any questions or comments. Thank you.